Hello, I'm Dr. Randall Sechrest, your host for eOrthopodTV, and today we're talking remotely with Dr. Erik Nilssen. Dr. Nilssen is an orthopedic foot and ankle surgeon who practices in Gulf Breeze, Florida. Dr. Nilssen did his medical school training at the University of South Florida, and from there an orthopedic residency at McGill University in Canada. He then completed 2 orthopedic fellowships, one in sports medicine and one in foot and ankle surgery at the American Sports Medicine Institute under the direction of James Andrews and Dr. Angus McBride. Thanks for joining us today, Dr. Nilssen.
Oh, it's a pleasure to be here. Thanks for having me, Randall.
Well, Dr. Nilssen, today what I thought we would talk about is a foot and ankle topic, and that's a very common condition called plantar fasciitis. And I think this is something that people have heard about as heel pain, heel spurs, plantar fasciitis. It goes by all sorts of names. So first, if you would sort of describe for me the current thinking and what plantar fasciitis is and help patients understand that.
I sure will, Randall. It's really a conundrum. We see it often, a lot of patients come in to the clinic. It's actually 1 in 10 patients are affected. And what it is, it's plantar heel pain, plain and simple. And there's a band of tissue in the bottom of the foot called your plantar fascia that's attached to the heel bone. And what happens is, and we'll get into some of the causes later, but that band gets inflamed and gets irritated and elicits pain. And that's what patients come to the office presenting as, is pain in the bottom of the heel.
And let's talk a little bit about the anatomy of plantar fasciitis. You're referring to this band of tissue at the bottom of the foot that connects to the heel bone, and I'm assuming that's what you're calling the plantar fascia?
Correct, Randall. It starts really in the base of the heel bone. In fact, I brought a model here, which this is the heel bone we're talking about. This is a side picture of a foot. And the band of tissue attaches right here, runs along the whole arch of the foot, runs along the bottom, actually attaches to the toes. And as one walks and jumps and runs, the bottom of that band of tissue under all those years while you're running and jumping is under stress, and it helps support the arch of the foot. And it's real thick, and it, like I said, attaches to that bone, and over time begins to get irritated.
And in terms of patients, when they begin to experience plantar fasciitis, what sort of symptoms are they going to feel?
Well, classic presentation is when you first get out of bed in the morning and put your foot on the ground, it's sharp heel pain. That's classic plantar fasciitis, and that's the most common symptom. Is when I put my foot down, it really hurts, and they sort of hobble to the bathroom or hobble in the morning while they're getting ready for work or school or whatever. And then as the day goes on, they seem to feel a little bit better. And then when they sit down again for a period of time, they elicit pain again upon standing up, just like they did in the morning. And the pain is pretty pinpoint located right in the bottom of the foot. Again, bottom of the heel, right along this area. It's really not in the back where the Achilles tendon inserts, more in the bottom of the foot and the plantar aspect, dead center in the bottom of the heel. And it may radiate along the arch a little bit, but that's the classic symptom, is pain.
And have we figured out, as orthopedic foot and ankle surgeons, have we figured out yet what is actually causing the pain?
It's an interesting question. We don't really, we go into the itises, so plantar fasciitis. We think of itis like tendonitis, is inflammation of the tendon. Well, it behaves like an inflammation, but the reality is there was a nice study done a couple of years ago where they actually took samples of the plantar fascia and looked under histology. Some really smart people did this, and they actually went in there and looked under a microscope, and it was not really an inflammatory process. It was actually due to a degenerative process, which is the microtrauma of pounding on the heel. So it's really not an inflammatory process, but it behaves like one. So in terms of the causes, like I said, microtrauma, the causes of this are really, we see it a lot in athletes, occupations where you're on your feet a lot of factory workers are standing on concrete floors a lot, a lot of long distance runners we see it in. And in America, we see a lot of it because of obesity. The excess weight pounding on the bottom of the heel causes it as well. plus different foot positions. We talk about people that have flat foot, or we say pronate or overpronators. That's the scientific term, which means you're flat-footed. We see it in that condition as well. And on the opposite end of that spectrum, someone has a very high arch. We call them, they have a cavus foot, or their foot is supinated. And we see that as well. And those are sort of the main contributing causes that we attribute it to.
Well, let's talk a little bit about the differential diagnosis and maybe some associated diseases. I guess to start, is this disease process associated with any other disease processes? Are people who have other diseases more prone to get plantar fasciitis?
There's some of the inflammatory conditions along with rheumatoid arthritis. People that have a tendency to have arthritises in certain joints have a tendency that affect tendons as well, have a tendency to get this. But globally overall, it's more so shape of the foot and, again, occupation driven. It's almost like an overuse type syndrome more so than a specific disease. And one thing I forgot to mention earlier, which is an interest of mine, is having tight heel cords, or the anatomical structure is having a very tight Achilles tendon. Some people are very, very tight, and those that have a tight Achilles tendon, I think, are more prone as well to have plantar fasciitis.
Well, let's talk a little bit about the differential diagnosis as we move into talking a bit about how you evaluate these patients. You know, I'm assuming that other things can cause heel pain as well. Anything else that runs through your mind when you're seeing patients that are coming into your office with heel pain that you might want to consider?
Absolutely. Any good physician should have a good clinical set of tools, and nothing substitutes for a good physical exam and also a good patient history. And the number one thing you have to really watch out for is when you're dealing, especially as an orthopedic surgeon, is bone fractures and stress fractures. And so calcanea, which is the name of the heel bone, a calcaneus, you could have a calcaneus stress fracture, which can present with heel pain as well. And we do something what's called a squeeze test. And again, here's my famous model. We can actually squeeze the heel together, and that usually elicits pain for a stress fracture. If we actually push in the bottom of the foot, that's more so the plantar fascia issue. But so from a fracture standpoint, calcaneal stress fractures, you got to really rule out. And the biggest overlap with plantar fasciitis, and it's often confused, and also will come in addition to the plantar fascia, is a neurologic problem. And under that neurologic problem is a whole gamut of things, and something called tarsal tunnel, which is very much like carpal tunnel of the hand, but you can get it in the foot. And there's a very large neurovascular structure that runs along the inside of the ankle, which runs right along that plantar fascia. It actually has a couple of branches. And there's some conditions where some branches of nerve can get impinged between different layers in the bottom of the foot. It can also mimic plantar fasciitis. So there's some nerve compression. There's a global nerve problem called neuropathy. And that's often attributed just to diabetes, when the reality of it is I see a lot of patients that have neuropathy that don't have diabetes. And that's just a global disease of the nerves. And so when you think nerve problems, you think some numbness and tingling associated with the foot. So when someone comes in and goes, my heel hurts, and I start asking, well, how long has it happened and how long it's been going on? Well, do you have any neurologic symptoms like numbness, tingling, burning? And they say, well, yes, both my feet seem to not have numbness or tingling in that. I start thinking around the neurologic symptomology such as neuropathy. And again, I also go back to just tight heel cords as well. And then there's a way of examining the Achilles tendon to make sure they don't have tight heel cords. And you often want to overlap it with the other side.
Well, let's talk a little bit about your evaluation. And first, how do patients actually come to see you? Are they referred by their primary care provider? Do you see patients that just sign up and say, I've got heel pain, and come in and see you and make their own appointments? How does that normally occur?
In a perfect world, I would love to have them all worked up by a primary care physician first, but unfortunately, it doesn't always work that way. But yeah, it's kind of a mixed bag. I get a lot of referrals from physicians in the community, which is one of the passions of mine, is through education and outsourcing. We have lots of teaching courses we do at our institute, but educating, primary care, mostly they're on the front lines about this condition. A lot of times they'll just say, well, patient comes in, while they're checking their heart out, they'll say, well, my heel's been bugging me for 6 months. They'll just write a referral, go see Nilssen, he'll take care of it, and we do. But but there's really no initial workup, which is kind of nice. So I get referrals from primary care physicians. We get a slew of patients that'll actually call as well and just say, hey, my foot's been killing me for 6 months, there's something wrong, and I want to see your foot and ankle specialist. And then a lot of times it's word of mouth. We get a lot of patients, again, they'll just call if a friend was treated by us or whatever. But usually those are really the three tiers and how it's driven.
So let's move on and talk a bit about the evaluation. When you see that patient complaining of heel pain in your office, how do you begin to evaluate their heel pain and what might be causing their heel pain?
First thing I always do is obviously take a very good detailed history. Things I want to know is, was there an inciting event? Simple things like, I was painting my side of my house and I fell off a ladder. Well, you're thinking trauma. Did the guy or he or she fall off and break their heel? Was that a missed before? Thing we didn't talk about earlier is, could they have ruptured their plantar fascia in a traumatic fashion as well, which is a traumatic situation as well, and you want to know that. But I go with a good detailed history, onset of pain, how long has it been going on, where exactly is the pain, point with one finger, where exactly does it hurt you, when does it hurt you, and what have you done for it, what makes it better, what makes it worse. And then from a physical exam standpoint, I always have them get out of their shoes, get out of their socks, have them stand there, and then actually do a little bit of walking, so I observe their gait or their walking first. Then I have them sit up on an exam table and do a thorough exam, starting off with some observation, palpation, range of motion, special testing, and specifically looking for pain really along the plantar medial aspect of that arch. Right in that area is where you get that point of most tenderness, if you will. And then to me, often overlooked, and which we'll get into more, I'm sure, is this tight heel cord issue. And the whole calf muscle, if you will, which is your gastroc soleus muscle unit, it's very, very important to assess if they have a gastrocnemius muscle contracture. And the way you can do that is, that muscle is very interesting, is that it's one of the few muscles that actually crosses two joints. It'll cross the knee joint and crosses the ankle joint. So by flexing the knee, you're relaxing part of that muscle, and you can attest, there's a way of checking, see if they have a gastroc contracture, and it's a very valuable tool and a very important physical exam finding when assessing patients.
And what about x-rays? Do you normally always get x-rays on patients who come in with heel pain?
I do. I just think it's a complete, my take is, I'm sort of a specialist in what I do, and I feel like when patients come to see you, they deserve really the very best you can give, and I think a complete exam, history, physical, and x-rays. And if they don't have them with us, as long as they bring an x-ray, and if they come without, they had an x-ray done 2 weeks before, they didn't bring it, I'll still see them, but I'll want that disc or I want that image dropped off if we can, so I can look at that x-ray. But I do, and I typically get just a standard foot series, which is an AP, lateral and oblique of the foot. And really, x-rays are really looking at bony architecture. They're not really looking at soft tissues very well. And even though this plantar fascia is a soft tissue issue, a hot topic is this, people come in all the time is, a heel spur. On x-ray, that's really what you'll see is a heel spur, coming off that insertion point of the plantar fascia. And there's been some very nice studies done where, basically in a nutshell, if we took 100 people off the street and x-rayed their feet, probably half would have a heel spur. But, when we have an x-ray and look at it, we're so honed in as to look for something. And so patients always say, well, my primary care doctor or someone said I got this heel spur, and that's what's causing the pain. And we don't think that the heel spur causes any pain. It just goes along with the pathology of plantar fasciitis. I think it's that more of a traction spur from the plantar fascia pulling on that calcaneus for so long. But again, people want to put their finger on something, and that's what they see. But that heel spur goes along the fascia. If the heel spur was going straight down in the ground causing pain, that'd be a whole other issue. But I wanted to say one more thing too real quick on exam, and something I did mention earlier is on the bottom of the foot in terms of the anatomy is something called the fat pad in the bottom of your heel. And it's very, very important. And as we age, I'm not calling anyone old, but as we age, the fat pad begins to atrophy, which means it shrinks. And so as we lose the protective sense in the bottom of the heel, we lose the protective sense in the bottom of the bone as well where the plantar fascia is, because that fat pad is made of these almost shock absorbers with fat in it. And you'll see is, take a heel pad of a 30-year-old and feel someone's heel in the bottom of it, and then go palpate a 75 or 80-year-old's heel, and you'll see a tremendous difference in that fat pad. And so as we get older, that fat pad begins to atrophy, and that's another thing I look at in exam as well, is always check that fat pad and always compare it to the other side.
Yeah, I think that's great advice. I do think that people are sometimes unaware of how the anatomy of the foot changes as we age, and how that lack of padding can lead to these painful syndromes. And maybe it's not plantar fasciitis, maybe it's just more of a condition that you just don't have enough padding. And you probably treat those a lot different, I would assume. Is that correct?
Absolutely, and I think, when someone has that fat pad that's given away, unfortunately we can't, we're not plastic surgeons, we can't take fat from someplace and put it in another, but it sure would be nice to do something like that in the heel. But as we get into non-operative treatments, if they do tend to have this plantar fascia on exam and they've got this really atrophied, fat pad, I certainly, I think, a lot of getting well with something is understanding what the problem is and educating the patient as to their anatomy and what's changing is very, very important, and they need to understand how this all works together. And so what I do is, if they do have some atrophy in the fat pad, I really emphasize trying to pad up that heel as much as possible with a type of silicone. It's almost like the texture of like a gummy bear or a gummy silicone gel. There's different heel pads, and you can get those at various stores off the shelf. But padding up that heel was very, very important with something very, very delicate like a silicone, or if you have an orthotist around, something they can make that's very accommodative and very soft to accommodate that heel.
Well, getting back to diagnosis, is there any role for any special tests like MRI scans, CAT scans, bone scans, or maybe even any blood tests that you would recommend that ought to be done when you see a patient that has heel pain?
After we talked about just getting a plain x-ray first, and sometimes if it's in the acute setting, I think if someone's like, hey, I was doing great, but they're in enough pain to come see you in a short amount of time, like, hey, a week ago, if they had obviously a major fall or something, they felt a pop or something, I will on occasion order an MRI, just because what I'm looking for obviously is, if you can't see it on plain film, would be a stress fracture. If I have a suspicion for a stress fracture in the calcaneus, I'll obtain an MRI just to confirm and give the patient peace of mind, knowing that we know what we're treating, ruling out fractures and also rupturing of the plantar fascia. And I've seen that. I've got patients that have ruptures of the plantar fascia. And really, in a nutshell, it's important to know, because in terms of length of time of healing, these ruptured plantar fascias take a long time to heal. We've even had some professional athletes that rupture their plantar fascia, and it's just good to let the agents and the teams and the managers and even, Johnny working down the street know, because it takes a much longer time for that thing to heal, and it's hard to get well when you're walking on something that's torn. But MRI, I don't really get bone scans, again, unless you're looking for a fracture, a acute stress fracture. But really the modalities, and ultrasound, which has gained a lot of popularity lately, is pretty neat. If you have an ultrasonographer, and we do have one in our office, which is really handy, it's a lot cheaper than an MRI, and with the cost of insurance and people's deductibles, it's very important, at least at this point, to keep that in the back of your mind, trying to keep costs down and help the patient out so they don't come out of pocket with tons of, some people have $1,000 deductibles or more, and they got to pay $1,000 for an MRI just to say, well, your plantar fascia looks thickened, or it's partially torn, or hey, it looks normal, whereas an ultrasound maybe cost them $100. So ultrasound's another interesting tool to use if you've got that accessibility. And also, it's good when we get into treatments in terms of localizing where the plantar fascia is for treatment, sometimes for injections, which we'll get to.
Let's move on and talk a bit about treatment. How do you start that discussion with the patient when you think that this patient is suffering from plantar fasciitis? How do you start the treatment process?
Well, the first and most important thing that I tell them every time, and it's like a broken record, is I tell them it's a 90 to 95% cure rate, non-operative. And so coming from a surgeon, that makes them feel pretty good. So that's the first thing I emphasize. I says, the chances of you being in that 90 to 95 percentile is really, really good. So let's not worry about the 5 to 10% that fail non-operative treatment. So let's just get you thinking along the lines this is going to get well. So that's the first thing I emphasize. And then a lot of it depends on what they've done before. Sometimes I have patients that have been treated for a year. So let's look at the patient that comes in, been sore for, maybe a month and a half, 2 months or so, and hasn't really done anything about it. And we've just gone through telling them what it is and that it's going to get better. And so my front lines of treatment, what I do and what the literature kind of suggests is the most important thing to do of all the things we do non-operatively is to stretch, okay? And say, well, what do you stretch? And it goes back to that, I said the Achilles tendon. The Achilles tendon, we're trying to change this whole concept of the Achilles tendon is much different or a different anatomical structure than the plantar fascia, but the reality is that Achilles tendon actually has some fascia that goes around the back of the heel and attaches to the plantar fascia. And there's been some very nice studies done by a group up in Michigan area that looked at this and did a lot of gastroc work in treating plantar fascia and saying a lot of pathology of the foot actually comes from the Achilles contractures. And so so stretching the Achilles tendon is the most important thing in my opinion to treat plantar fasciitis, and also stretching the plantar fascia. And how do you stretch the plantar fascia? And it's really a dorsiflexion, so bringing the foot to the face and extending your toes and taking a belt or a band that you can get with a therapist to pull up on that to stretch the Achilles tendon and also the plantar fascia. So stretching is number one, most important. Number two, I'm a big believer in some anti-inflammatories, and I'm an Aleve believer. I don't have any royalties or anything with Aleve, but I say 2 Aleve in the morning and 2 Aleve at night, which is really naproxen. And so get them on some type of anti-inflammatory. Sometimes you can do a prescription like a Celebrex or something, but get them on some anti-inflammatory. And I also give them a handout. I've got a handout that I have developed with some therapists that has a protocol to go through in terms of what to do and what not to do and wall stretches. And then I also tell them to put a golf ball in the freezer or take a frozen water bottle, and they roll the bottom of their foot over that frozen water bottle or golf ball as often as they can. I think also with a, do it with a rolling pin, if you will, as well, just to desensitize the bottom of that foot, and that'll help too, just to desensitize the bottom of the foot. And then and really, I do that, and I have them come back and see me in about 6 weeks. That's kind of my frontline go-to maneuver. I also have them, maybe even if they are interested into it, go to a physical therapist to show them once or twice some home exercises to do as well. But that all depends, again, on back to the insurance thing. If they have high deductibles and they don't really want to spend the money, then I give them that home program.
And I'm assuming that given the fact that 90-95% of these folks are going to get better with non-operative treatment, do you expect them to come back with a significant amount of improvement at that 6-week visit?
My expectation is, number one, as long as they're getting some improvement, I'm happy. We're heading in the right direction, and then they feel that way too. Reality is, I usually see after 6 weeks, most patients say they get about 40 to 50% better by about 6 weeks, but they've got to be, it's a very disciplined approach, keeping a belt or a band by your bedpost, and when you wake up in the morning, because that's the most, like we said about, in terms of pain, the worst pain is first thing in the morning. So I have them keep something by their bedpost or their bed and get up 5 minutes before they get out of bed and stretch that Achilles for 5 minutes before they get out of bed. And then again, it's 2 or 3 times a day, and so it's hard to get people to really understand, especially when they're stretching 2 or 3 times a day for the first 2 weeks and not really feeling any relief. Because our society, we want instant gratification, and they're not going to get that with this. This is a marathon, it's not a sprint. And so I'd say about 40 to 50% relief are my expectations 6 weeks into this. But as long as they're getting better, we just stay the course. And then the other topic is, in terms of non-operative treatment, is, what about injections? Well, patients that have been treating for a long time will come see me and they'll have 7, 8 injections in the bottom of their heel, and that's a real problem because we talked about the fat pad, and I think injections, there's a place for those, and the injections we're talking about are kind of a mixture of a steroid and a numbing medicine, and having the luxury of having an ultrasonographer at my disposal, it's very, very important and nice luxury to have an ultrasonographer anatomically view that plantar fascia on a screen, come in with a needle, and hit that plantar fascia insertion every time. I think I know my anatomy and I feel I'm good at what I do, but there's been numerous studies in different anatomical structures where they've used cadavers and under imaging have a bunch of doctors figure out where the plantar fascia is, or even different shoulder injections, knee injections. Been some nice studies. And, you know, I'll be honest with you, I think there's probably a 40 to 50% hit rate where it needs to be. And if you miss that plantar fascia and just keep injecting that very, very important fat pad, it'll cause some fat pad necrosis, and that fat pad will atrophy and accelerate that thinning of that period and actually make things worse. So I do inject. I inject after they've really given it a good stretching, anti-inflammatories, frozen water bottle, desensitizing the bottom of the foot, been through physical therapy. Then I may do an injection at that point, and then at most I'll do 2 per year. But right before, if they're like at the cutting edge, or they say, look, I just can't handle this anymore, that's my threshold to do an injection. But I certainly don't encourage injections right off the bat.
What about orthotics? Do you believe that most of these folks are going to benefit from some type of addition to the shoe, or some type of modification to the shoe?
Yeah, I mean, that's orthotics are, you know, I don't know if they're like wine, and they're kind of like beer. They're all not the same, and so orthotics, you know, you have to have a good understanding of orthotics and how they're made. A lot of times people say, we have plantar fascia, here's an orthotic. Well, you know, it's not that simple. And so I think back to the foot structure we talked about, if somebody has a flat foot and they're overpronating, I don't see any reason it wouldn't hurt them to at least introduce them to orthotics. And depends, I want to get a custom orthotic or an off-the-shelf one. But a custom orthotic with a nice medial heel counter, a full-length total contact orthotic that's custom made for them to help support that arch, potentially will help them. Again, it's kind of a mixed bag. Some people it helps, some people it doesn't. And vice versa with the high arch people. If they're really high arched, something laterally to kind of post their arch up a little bit. But taking pressure off that plantar fascia is hard. To me, the more realistic approach is we talked about with those heel, just a heel pad or a heel counter to help that, you know, help support that bottom of the heel is more advantageous than anything else.
Do you make any recommendations in terms of shoe wear? Is there a type of shoe that you feel like works best for people with heel pain versus other types of shoes?
You know, the shoes that I like to use are, you know, I would recommend in terms of helping with heel pain are going to be your sort of your running shoe or your jogging shoe. You know, someone comes in with plantar fasciitis and says, hey, you know, my heel's bugging me, and they want to wear a high heel shoe. That's a problem. So in that time where they're really trying to get this pain under control initially, is I encourage a running shoe. You know, a hot topic too are those little rocker bottom shoes, the Skechers rocker bottoms, and some people really enjoy those, some don't. It just depends, but a well supported athletic type shoe is something that I try to push initially.
And what about if they fail all these interventions and we're getting to the point that the patient is somewhat discouraged and frustrated? When do you begin to have the discussion about surgery? What drives you to have that discussion with the patient?
Well, again, it's, you know, I 6 months is sort of still early to me. I tell them, hey man, you really want to go a year, and then a lot of times, like, they'll come see me and they've had it for a year and a half, and they've done all this stuff. They've done therapy and injections and orthotics, and so my go-to question is, you know, is this affecting your activities of daily living, and can you live with it or not? And it's just a judgment call on the patients. If they say, listen, I've done everything I can't live like this anymore, kind of sets off a little alarm bell in my head. If they say, well, it bugs me, but, you know, I can kind of deal with it, I'm kind of tired of it, I say, well, you know, then I kind of just say, well, maybe we should just, you know, re-examine what they've really done and say, well, this is the stuff that I really like to emphasize. But my threshold is I got a pretty high threshold before I pull the trigger, and then what to do surgically is also can be debated.
Well, and let's talk a little bit about that. What is your approach surgically to plantar fasciitis? What sort of procedures do you feel are recommendable?
Well, the gold standard, which is sort of the tried and true way of doing it, is to go after the plantar fascia, that insertion site, and the gold standard is to go in and release or take out a little piece of part of that plantar fascia. And the thought process is by taking some of that out, you're releasing some of the tension that's pulling off that insertion site, and patients get better. I personally think that it's just the surgery itself which is eliciting a healing response by bleeding and bringing healing factors and growth factors and like stem cells, for example, to that area to help it heal. That's the gold standard. And then from that, there's also, people advertise, well, I can do it endoscopically with a camera, but my concern there is the anatomy. There's lots of nerves in that area. I personally feel like, so the incision is twice as long, and we're still talking about a 2 or 3 centimeter incision, so big deal on the side of the foot. I personally, if the mainstay of treatment is to stretch the Achilles tendon, to me it made more sense to work on the Achilles tendon. So of late, and this group in Michigan kind of did a huge study on this, and I've done the same myself and have tremendous results, is I prefer going to, if they have an Achilles contracture or a Gastroc Recession, my first go-to is doing what's called a Gastrocnemius Recession. So we make a little small incision in the back of the calf and do a partial release, or we'll pie crust part of the gastroc fascia in the back of the leg to release. It's almost like a poor man's, or a quick way of stretching your gastroc fascia. And so it's like doing physical therapy for 6 months every day. If I can get that foot up an extra 10, 15 degrees of dorsiflexion, I've found tremendous results. And patients, I do that procedure. It takes about 6 minutes downstairs in the surgery center. It's an outpatient procedure. I keep them off it for 2 weeks, and then I put them in a boot at 2 weeks, as long as the incision looks okay, and encourage them to start putting some weight on it and start going back to that same non-operative modality of frozen water bottles and stretching, more stretching, some anti-inflammatories. And so this Gastroc Recession, in my hands, has been sort of a revolutionary way of treating plantar fascia. We don't burn any bridges. There's an important sensory nerve in the back called your sural nerve, and we always identify that, and knock on wood, we haven't had any sural nerve issues. And then the biggest complication sometimes is push-off strength. Some people will lose some of their push-off strength, and so I wouldn't recommend it in a LeBron James or a Kobe Bryant at this point, but I think that we don't burn any bridges, and you're not operating on the bottom of the foot. And so I've done Gastroc Recessions, and knock on wood, I haven't had to go back and do anything else. And so it's worked very, very well. And if it doesn't work, then you can go to the plantar fascia release, because there's different studies out there, but overall, looking at the results of that surgery, it seems to be kind of a mixed bag. I mean, I tell patients it's about a 60%, success, or patients are very happy they did it. So to me, that's not a very good result. I mean, I don't want to tell someone, well, we got about a 60% chance to make you better in surgery. We like surgeries that are 85% or higher.
Well, I hear that. I think your points about operating on the bottom of the foot, where we're walking every day, are very important. And I think patients need to really step back and understand that scarring, anything that affects that weight-bearing surface, can lead to significant problems. So I like your approach. I think that it's a very conservative approach, and it probably, the patients that you take care of sound like they're in very good hands, at least from decision-making standpoint. I also like this new approach. This is a major change from what we used to do in terms of surgical approaches to the plantar fasciitis problem. There's been a lot of different things described that over the years that are an attempt to try to address the real problem. It sounds like the real problem in plantar fasciitis may not be the plantar fascia at all, and may be more the biomechanics, as you've pointed out, that you're really addressing with the surgery that you're now doing. So that's good information for patients, and good information for surgeons and people who are taking care of plantar fasciitis and heel pain in general. Anything else you think patients need to know in terms of making the decision, is surgery right for me, or have I waited long enough, or should I continue to do my physical therapy and my stretching more religiously, and maybe that's still going to get me the benefit that I want to see? Any good advice for patients?
Yeah, I think that, you know, it's again, in the Gastroc Recession is pretty radical, but again, I just feel like, you know, and some surgeons may watch this and say, man, that's, you know, I don't know about that. Well, you know, like I said, I've got 40, 50 patients that have, and I collect clinical data on my patients and been very, very happy, and they have too. And so I think to me, it's one of the game changers. And again, we're looking to game change and change medicine. But I would tell patients that, again, I mean, stretching, you can't stretch enough. None of us stretch enough anyway. But you have to really exacerbate everything you can and dedicate your life to 6 months to a year of hardcore stretching. And I really believe, you know, if people really did that, and again, it's that whole instant gratification. I mean, it's anything worth having is worth working for. And so to avoid surgery, and I kind of scare them. I was like, you don't want surgery. You know, it's not a good surgery. But the ball's in your court, and so I would basically really give it a you know, 3 days, three times a day stretching, anti-inflammatories, frozen water ball, but dedicate your life to that issue. And you know, it takes a full commitment. And if you're married, you're not married, you got kids, it takes a family commitment to understand what you're going through, and let them know what you're going through, and to leave reminders in the house or post-it notes. But you've got to be very, very proactive, and I would encourage you to, you know, with your physician, it's all about, you know, empowering the patient, empowering you to do it. My job isn't to enable you. I mean, if a surgeon tells you, oh, you know, you got to have surgery, you don't have to have anything. Okay, you know, it's your life, it's your career, it's your health, and so, you know, you need to know all the information before you jump on something. And to me, surgery is a big deal, and even though it's, you know, plantar fascia, what's the big deal? Hey, I've seen it, you know, change people's job. I've seen it change their life. I've seen them not be able to play in sporting activities. It's a big deal. So, but really take ownership of your problem and stretch like crazy.
Well, a couple other questions about a couple of treatment modalities, one that's been used in the past and one that's relatively new, and that is, are we still using the technique that we're using on kidney stones? At one time, people were trying to use that lithotripsy, where we use sound waves on the heel and tennis elbow and that sort of stuff. Is that still being done on the heel for heel pain?
It's a treatment I didn't mention, and I'm certainly glad you did. I personally don't have it's a machine that elicits this wave, and the thought process is exactly what you said is kidney stones. They use this to break up kidney stones and breaks them up into smaller pieces so it can pass. And my understanding of this technology for plantar fascia is these waves are emitted, and it's quite painful. So it can be done in an office, but they typically will numb the heel up, or maybe some light sedation or a nerve block because it's painful. And it's one of those non-operative treatments. It's used to hit the bottom of the heel, and it's a pulsatile jolt. And the thought process is just stimulate some healing response. And so what I think what it does is it causes some micro tearing of the plantar fascia, maybe some microscopic bleeding. And blood is what carries all these growth factors and stem cells, which is a new hot topic now as well, to the area to elicit this healing response and heal it up. But the studies out there have shown that, you know, it's been pretty promising. I mean, you're looking at about, you know, there's 2 randomized controlled trials that were done that I most recently read about, and it's about 70% to 80% effective. But I think one of the issues is, not to sound like a broken record, is insurance coverage. I think some insurance coverages won't cover that. And so I know locally in this area, there's a couple podiatrists in town that have a machine. I don't have one personally, but and it's an option to bring up, and I don't know, sometimes insurances cover it, sometimes it's out-of-pocket expenses, but I don't think overall in the grand scheme of things it's that expensive. But that's certainly an option, and it seems like it's pretty reasonable at times, but you got to just know where to send someone, or if your doctor has one.
Well, and the other modality I'm talking about is PRP, or the platelet-rich plasma. You know, we're using this, injecting this in areas where we're trying to elicit these healing responses. Anybody using that in plantar fasciitis to any great effect?
Yeah, it's funny you mentioned that. Just last month, a nice article came out, and PRP is sort of, we've been looking at this for a couple of years now, and all very promising. A study came out for an Achilles problem and showed no difference. We're like, oh, there you go. Well, study came out for plantar fascia. So nice randomized controlled trial, very promising results and very effective for plantar fasciitis. The results are very good. So there is a place for PRP, and it's a concentration of the platelets, which has the growth factors and the healing factors in it, in the plantar fascia as well. And that's again, we've had we have a regenerative center where we're at, and we're very much into PRP and some stem cell treatments, which are I think the wave of the future. But some insurances will cover that, and a lot of times we can call ahead of time and try to get authorization. And PRP, again, it's like a 50-50 deal. In some cases aren't, but if the patient has to pay cash, on average across the country, I want to say it's around $500. But we just draw some blood from your arm and we put it in a centrifuge, and it's your own blood, and we just basically re-inject where the site of injury, the site of problem is, a concentration of your own platelets, which has these healing factors. And but the problem is patients want to pay cash, and it may not work. But again, it's got to be injected with ultrasound, and because you can imagine, like I said before, if we're injecting steroids there, and you got a half shot of hitting it, with a good ultrasonographer, they could visualize that and then hit you with the PRP right in the plantar fascia. But the only study that's out, randomized controlled, has very good results, and which is a very viable option.
Well, we'll definitely keep our ears open for more information about that, and maybe we can talk about that in the future if you find additional beneficial studies that this is going to be one of the treatments of choice in the future. So as we close today, I want to thank you for all of this information. I think this was a very comprehensive discussion on plantar fasciitis, and I think patients watching should have a very good basis for making decisions. So look forward to further discussions in the future, and I want to thank you for joining us today.
Oh, Randall, my pleasure. Thank you so much for having me on. Thank eOrthopod as well. It's been great, and look forward to talking to you again.